Hello, I'm Tony DeMaria, the editor of JACC, and I'm here with another edition of the Genuine Article. And what I'd like to discuss at this particular time is the material that was in an editor's page that I prepared for a forthcoming issue of JACC. And that editor's page dealt with manpower, and the topic really was stimulated by two articles that appeared recently in the New England Journal of Medicine. One article by Dr. Eigelhart pointed out that there was anticipated to be a physician shortage that in the near future, and that in fact this concept of an impending physician shortage had been agreed to by most major organizations, and that those organizations, including medical colleges, were now ramping up to increase the number of graduates. Now, in the same issue of NEJM, there was an article by Dr. Goodman that said this probably does not make a lot of sense, that in fact, while we may be a bit short of physicians, the bigger problem is the geographic distribution and the distribution within specialties, and whether or not we have enough physicians for the specific needs of our society. In any event, having read these articles, I began to think about this manpower issue. I think there's no question in my own mind personally that there will be a physician shortage in the future. In fact, I've seen things change among our own cardiology fellows, that they have lots of job opportunities at attractive salaries in attractive locations. So what I'm seeing really does substantiate a lack of physicians. But even if we look at the demographics, medical school enrollments have largely been fixed for the last 20 years while the population has been increasing. And in fact, physicians have been very frequently now making lifestyle decisions, working a lesser number of hours. I'll come back to that. So that the physician pool really has stayed relatively constant while the population has expanded. In addition, we've got an aging population that has much more disease and that has a greater inclination to seek medical services. For us in cardiovascular disease, this is particularly important since coronary artery disease remains the leading cause of death, and particularly in an older population. In any event, just getting away from the specific question of whether or not there'll be a physician shortage, there were a couple of aspects of these articles that particularly caught my attention. Now, I've been in cardiology for over 30 years, and during this time I've seen a dizzying change in perspective in terms of whether or not we had a physician excess or shortage. When I was a cardiology fellow, it was widely believed that there was a physician shortage, and we were increasing the fellowship positions for cardiology training and, in fact, expanding medical schools. By the 80s, it was widely believed that there were going to be too many physicians, especially too many specialists. And it was widely said that if, in fact, all medical services were provided in the way that medical services were then given in managed care, that we'd have a massive excess of cardiologists and other specialists as well. Now we're coming 180 degrees again, and there's a physician shortage. Now, these projections of physician excess and shortage are not without their consequences. And I can recall talking to medical residents who wanted to become cardiologists but were very reluctant to enter fellowship because they were uncertain that they would ever have a job available to them when they finished. Now it looks like we're going to be playing catch up. The thing that really has impressed me is that although these projections obviously have not turned out to be accurate, as evidenced by the waxing and waning of excess and deficit of supply, they've always been promulgated with enormous confidence. So the people may not have been correct, but they certainly have always been relatively confident, and that certainly holds true for the current projections. Now, there are a couple of other interesting aspects of this that struck me. One is the influence of lifestyle. We're increasingly seeing among younger cardiologists, certainly among medical students and residents, that they are making lifestyle decisions, that they are choosing not to work the long hours that physicians have in the past, that in fact they're looking for stable hours and more predictable working circumstances. Now, that's obviously creating a consequence on the physician workforce, in the sense that the physicians we have available seem not to be putting in the long hours that physicians did 30 or 40 years ago. And obviously, even in our trainees, they work fewer hours. And so this will be a factor. It's of particular interest that the role of female physicians have been brought into this consideration, because studies would indicate that women as physicians work about 15 to 20% less in terms of hours than their male counterparts. Now, women obviously have a number of reasons for this. Our society still, rightly or wrongly, has had expectations for women in terms of a family role that were not the same as men. And so women are increasingly drawn not only by their responsibilities medically, but their responsibilities to the family. It is clear that we have not had enough women in cardiology. Females now comprise about 50% of medical school classes, and if we're going to get the best and the brightest of those medical school classes, and if we're going to get an appropriate number of new cardiologists, we are going to have to attract women into our specialty, and that means we're going to have to look at our working hours and particularly at the unanticipated emergencies and the on-call responsibilities, and that will present a challenge to us. And the last aspect of this manpower issue relates to international medical graduates. They've certainly contributed enormously to cardiovascular medicine, not only in terms of providing clinical care, but also in terms of academic leadership. But obviously, when we attract international medical graduates to the United States, often from just developing countries, we are taking very precious resources from those countries, and that creates an ethical dilemma. I think really we need to look long and hard at whether it would be in any way ethically justifiable for us to look to these very fine international medical graduates to fill our impending need for physicians, and in the process deprive their countries of very badly needed professional resources. These are all difficult questions, all unresolved. But clearly manpower will remain on the front burner for the foreseeable future. Thanks very much for viewing this. For the Genuine Article, I'm Tony DeMaria.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.